Good afternoon, everybody. Thank you for coming along this afternoon. I appreciate it. What I'm going to talk you through this afternoon are some of the learnings that we have gathered on running programs over the course of the last number of years. So whoops. Can I see the screen myself? There we go. So we start every journey, obviously, with the patient and understanding that patient context. So in that regard, every condition is different, every treatment is different. Some patients are accepting of their diagnosis, some of them are in denial, some patients are engaged with their therapy, and others are much more skeptical. Okay? But what we see then as we go through that is that digital offers this opportunity to engage with patients throughout that process and to get a much richer understanding of what they're experiencing. And our friends at Accenture provided this statistic with regards to how patients are currently engaging with technology, which may dispel some of the myths that are out there, that patients are willing to use technology and they're seeking to it. In fact, there's another statistic out there which showed that 53% of seniors are using technology a few times every month to help manage their conditions. And I can show you some data with regards to that as well. So when we look at how the patient journey progresses, and I think we're all familiar with call centers and traditional patient support programs that are more human interaction based. And they do work and they are effective and we think they're a good thing. But at the same time, they are somewhat of a one size fits all. Okay? They are typically very structured so that the significant majority of the interventions with the patient tend to happen on a predetermined schedule, predetermined at the start of the process rather than necessarily based on what the patient is experiencing over that time. And what digital enables is that we can be there with the patient throughout that journey at different points along the way. And as a result of that, we are not just providing them with continuous support rather than episodic support, but we are also enhancing the contact that they do have when they engage with the call center or their clinician or whoever it is. So if we take that as an example, and we see it's quite interesting when we look at the process that there's a trend happening now within healthcare which is moving away from a reactive care model and more towards a proactive and continuous care model. One where it's ideally trying to reach that, I suppose, that holy trinity of extending the patient's life, improving their quality of life, and lowering healthcare costs all at the same time. But in doing that, we also see that patients have much higher expectations as a result. And those expectations are coming not just from within the healthcare industry, but also from consumer applications and solutions. So for example, if I'm using my Alexa and I ask it to play some music on Spotify, I expect it to work. And we have to be cognizant of that. As a result of that, when it comes to the interventions that patients are looking for, they're looking for something that's more than the generic solution. Just because you know that I'm vaguely interested in cooking, I probably have a higher expectation than simply getting some recipes about healthy eating. Instead, what I'm looking for are highly relevant, contextualized interventions that will help me manage my condition better and hopefully positively influence my behavior so that I have better outcomes as a result of that. So this is an example of a program that we have been running for the NHS in the UK. We've been running it for about 6 years. And it's an example of how how digital can assist both with the understanding and the enhancement of the program. I should point out, by the way, on this one, the average age of a patient on this program is 71 years old. The adherence level to their care plan after over 2 million patient monitored days is 98%. If you design a program correctly and you take account of the audience, you can get them to engage. There's a number of different aspects to that. They have to feel that you are delivering real value to them. They have to understand what that is. And in that regard, we designed the programs very carefully. So in this case, we had a very simple decision-making tree when we were gathering data from patients. So we were asking them questions such as, is your sputum green? Yes or no? Are you more short of breath than you were this morning? Yes or no? Is your pain better or worse than yesterday? Yes or no? You make the decision, you make that data gathering very easy. And we use validated questionnaires and surveys during the course of our programs, but the key there to understand is that we're not asking all 40 questions at the same time, and we're not asking them 3 times a week. The key is about using those questionnaires in an appropriate manner so that you're asking the right questions at the right time to enable you to get as much information as possible to build out the whole of that picture. In this particular case, what's involved, just to give you a feel for the program, it's an enhanced program. There are 10 different connected devices the patients are using. Any one patient would use probably an average of 4 or 5, depending on which combination of conditions they have. There's 4 conditions covered: chronic heart failure, COPD, diabetes, and stroke. The data is gathered passively, so they step on the weighing scales, the data is captured, they don't need to press any buttons in order for it to be uploaded. They use the thermometer, they use the blood pressure monitor, the glucometer, whatever it is. There's no need for them to take additional actions. We then digitally triage that data against personalized parameters for each individual patient, and we have to have that done by 10 o'clock each morning. And we then raise alerts to a call center based on that, mild, moderate, and significant, and they then prioritize their resource based on those alerts as to who they should call. So rather than simply randomly calling the whole of the population, their initial calls are based on a prioritization based on the alerts that are coming in each day. They in turn have a service level agreements in place whereby they escalate alerts that they feel still need to be escalated further after that phone call with a visiting nurses program from the NHS. That has to be done by 11:30 each morning. And if necessary, then a nurse will visit the patient that afternoon. So what it shows is that technology can be used by older patients. It's a great way of managing your costs. It doesn't necessarily mean that a digital program is an incremental cost. Actually, it can significantly lower your costs if it means that you need less seats or less resource for your traditional patient support program. Okay. So if we look at then how we design those programs, and I referenced earlier about ensuring that patients are getting value from them. In fact, all the stakeholders are getting value from them. One of the things that we have learned over the course of the programs that we've run is that there are some common traits that come through. And these are some examples of quotes that we've seen, and they're atypical. So in the first case, we see that the patients are looking to feel that they are in control, that they're not handing over control of their therapy to somebody else, and that they are divorced from it. The second is that they feel that they are informed, that they know what's going on, they're part of the decision-making process, and not detached from it. The third is in the area of feeling of feeling understood. So they want to know that the person in the call center or whoever is engaging with them really does have an understanding of what they're going through, and that they're not applying their view of the overall patient population to them because they feel that, well, it's a little bit different for me, whether it is or not. And the last one is, not surprisingly, that they feel safe. And I'm going to come back to these a little later on with regards to how we use them as we design the program, but they're quite key as early stage milestones from our perspective. Okay. So I think most of the audience here will be familiar with moments of truth, so major decision-making points along the patient journey that determine how a patient engages with their therapy and also what their perception is of that therapy. And Google have coined a phrase recently, which is micromoments. I've taken their exact definition of it. And what they are seeing are occasions when people are instinctively reaching for a device in order to answer a question or get an opinion on something. And we all do it at different times of the day. In the middle of pub conversations, I don't know about any of you with children, but I'm struggling to get some of my ones to look up from the screen when they're having a conversation with us. And these micro moments are key then in understanding that patient journey and how we engage with it. So what we are seeing is that we have to understand that patient journey, understand what information the patient is looking for at a specific point of time. Maybe they're looking for, trying to work out if the treatment that has been given to them is appropriate. What are the side effects that I'm going to experience? Is the side effect I am experiencing normal, or actually is that something I should raise? The injections, I'm really struggling with them, and I need somebody to explain to me how to find alternative injection points. And the other aspect that we often see coming through now is patients taking treatment holidays. So this is particularly relevant when you've got a treatment where there's a deferred consequence. So if I take off my glasses, obviously, it's pretty obvious to me that I'm not going to be able to drive very far without crashing. On the other hand, if you've got a treatment whereby skipping an occasional dose doesn't seem to make that much of a difference, well then I'm going to tend to do that more regularly, and eventually it will become a habit, and then we have a significant compliance issue, and whether the treatment is effective or not is another issue. Okay, so what we're trying to do as a result of that is to answer those questions not in a blunt manner. So we've all heard those stories of patients who've gone to websites, been overwhelmed by the information that is there, scared of it almost, and run away and stuck their head in the ground and decided not to engage with their therapy. What we're instead trying to do is identify at a particular point in time what a patient's information needs are, based on their personal circumstances and the context of the situation, and to then address those needs in a relevant manner. And the objective, of course, is to ensure that their compliance increases overall. So how do we go about then engaging with those patients at different micro moments along the journey? And essentially what we do is we use some of our experience, and we use some of those quotes earlier on to initially co-create the programs so that we develop a minimum viable product as early as possible, and then use to iterate that with patients and with clinicians if relevant as to what the experience should be. And what that enables us then is to not just to be there along the journey and have a comfort level with them, but back to those earlier points that I pointed out with regards to how the patient is feeling. These are the attributes that we look for in a program, both as we design it and as we subsequently manage it, to ensure that we are delivering value to the patient. So we use predictive analytics in order to look for certain keywords within patient verbatims and feedback that is coming in as to how they're feeling, how they're getting on. We're looking at adherence levels and how they're engaging, not just with their medication, but also their treatment, and also with the patient support program itself. And as a result of that, what we then do is optimize the program on an ongoing basis. So we're looking to not just feed into it, as I said at the start, but hopefully programs continue to get developed and optimized over time. That doesn't stop at the point of launch. So what we often get asked then is, okay, so that's great. Understand that we should be engaging with patients, but how do we determine what the actual interventions are? And this is an example of a program, of a model, I should say. It's called the Necessity Concerns Framework. It was developed by a behavioral company that we work with called Spoonful of Sugar. And what it shows is, if you have a look at the left-hand side, you can see that, and there are various validated questionnaires, I should say, that determine where patients fit on these axes. That patients are on an axis of whether they believe in their treatment or not, or whether they are skeptical or ambivalent to it, and also looking to understand what their concern levels are with regards to their treatment. What we see on the right-hand side is that there's a very high correlation between those patients who either have a high level of concern or have a low understanding, low level of belief in the treatment that they are on. What this next graphic shows is quite interesting. This was a small study done with 77 HIV patients, and there were no interventions done in this model. And what we see over time is that patients naturally progress from that quadrant where they are accepting of their condition, and they will naturally gravitate towards non-adherence. And that's what we're looking to address over time. Patients need to be supported rather than simply leaving them to their own devices. So in terms of determining what those interventions are, as I said, we start off with understanding, well, what is the patient experiencing? Okay, and you need a rules-based engine, to be honest, to do this. So we start off looking at their actual behavior. Are they taking their medication or not? Are they taking their steps? What other aspects of their therapy should be doing? How are they feeling? And we use validated questionnaires to gather their symptoms with very simple to use interfaces in order to record their feedback. What are they experiencing at the moment? Am I anxious? Am I nervous? I'm actually pretty frustrated with my treatment at the moment, or I don't believe that it's working. We look at their belief system with regards to their view of medication. So am I the type of person that only takes my medication when my symptoms are very prevalent? Am I the type of person that takes it when I'm told to? Or am I the type of person that will stop taking it as soon as my symptoms disappear? And then we look at the population norms. So given where a particular person is on their condition journey and also their treatment journey, what would be normally expected for them to experience at this time? The last piece is then developing a behavioral model for that specific therapy area. There is no one-size-fits-all in this space. And you have to develop deep insights in order to inform those behavioral models in order that they actually work. So we develop insights not just for example, oncology as a whole. We will develop ones for specifically multiple myeloma or neck cancer or whatever the area is. And what we see on the left-hand side is an example of an intervention. So in this case, Maria has, I think it's atrial fibrillation. And we can see, Maria, you're not getting much exercise and you're feeling tired. And how do we know that? Because we're gathering the data from her activity tracker. And how do we know she's feeling tired? Because we've asked her one or two questions that have indicated that that's the way she's feeling. And then the information that we're providing to her is highly relevant to that feedback. And that feedback can come in a number of different forms. So here's an example of one for a different patient. It could be a digital intervention, it could be a piece of video, it could be a short article. Depending on the therapy area, it could even be a white paper if someone was particularly information hungry. Or it could be a human intervention. So maybe the most appropriate interaction is not a digital intervention. Maybe what we should do is escalate it to that call center and you have a human interaction or intervention. Or we raise an alert with the patient or with the consultant, depending on the therapy area, of course, and how engaged they are, to suggest that they meet up. So in order to deliver this at scale, you need tools. So what we see on the left-hand side are various patient touch points that we use in order to do that. In the middle, you see some tools. I believe, by the way, the slides are available afterwards, so I'm not going to go through them in too much detail, and I'll keep going. And those tools enable us then to deliver certain services and a customer experience. Okay, so on the left-hand side, what we're seeing is how the patient is feeling. In the center, those services are enabled by those tools that we put together, and they're fairly standard and common set of features that we've used. On the right-hand side, what we're seeing are additional touch points for other stakeholders outside of the patient. So if the patient has provided consent, then we can provide clinicians with oversight and a deeper understanding of what the patient is experiencing when they meet with them. And also likewise to the call center. And on the bottom right, what we're seeing there is de-identified and anonymized data being provided to Pharma, so that you can interrogate it, slice it and dice it, look into different patient cohorts, develop reports for market access programs, and so on. And that aspect of ensuring that we are delivering value for other stakeholders is one that I think can't be ignored. So we do talk very much about developing patient-centric solutions, about co-creating the solution with patients. You can't ignore and you can't be mindful enough of ensuring that we have aligned all of the objectives for different stakeholders to ensure that they engage. So in Pharma's case, it's often about enabling you to have a deeper understanding and gather that data. And that then feeds back into a number of different aspects. So you've got richer programs that you can deliver because you can improve them and optimize them. You've got data that's feeding back into your clinical assessments, into your market access reports, and so on. And the last slide then I will leave you on is this. So we have these tools in terms of how we can engage with patients. And understanding how they enrich the patient journey at various points along the way. And from our perspective, we see two main aspects that digital programs deliver. The first is that they have the potential to extend the reach of your patient support programs significantly. Okay, because you're now no longer limited to, I only have the budget to make 4 phone calls to the person over the course of the first 12 weeks of the onboarding program. The second is that you can enrich that contact that you do have, and enrich it not just during the whole of the journey, but also on those few points where you are reaching out to them from a traditional support program. And I think there's a bit of a call to action there with regards to how you engage with that, to see an increase in the effectiveness of your therapies, an increase in the effectiveness of the patient support programs. There's a lot of talk with regards to it. And we're seeing some of the industry leaders move this direction, but it'll be interesting to see how it progresses. So thank you very much.
Thank you very much, Matt. So we've got a few questions, and I think we've most probably got time to go through the vast majority of these, actually. The audience is asking the first question, which is how do you deal with data security protection across Europe, being one database or a different one in each country? And maybe you could, there's also a question that I saw around the role of pharmacovigilance. So data security protection, the databases, and then maybe you could answer the question about the role of pharmacovigilance in the development.
So the data protection aspect is an interesting one. You have to look at the permutation of the countries that are required at any point in time. So we have cloud-based solutions, I would say typically for a global rollout, it depends on the permutation of the countries, but you do need multiple data centers, and I would say somewhere between 5 and 6 would be a typical rollout for a global solution. It really does depend on which countries you're dealing with as to where the data needs to sit within that. The pharmacovigilance one?
There was a question, I saw it on the screen, maybe it hasn't come up, about some of the data you're collecting. What role does pharmacovigilance play in the development of the programs that are being rolled out? Admittedly, that does have to be handled carefully. So, for example, what we don't provide is the option for patients to use free text to describe everything that they are going through in their life. So that is simply unmanageable from our perspective. It's very difficult to extract any learnings out of it. It needs to be somewhat more structured in order for us to do it. So the feedback that is provided is more structured, but when it comes to, for example, managing side effects, we give them a predetermined list which is based on side effects that are known to have happened during the course of clinical trials. Okay, thank you. The next question is, you stated 90% of patients are willing to use the technologies, but how can you ensure that 90% actually have access to the technologies? Is there the question for the audience?
No, I think that's a fair question. There are countries around the world where smartphone penetration is quite low, and a digital program is less appropriate for those countries. I'd also say that while we think that the upper age limit on patients using technology is significantly higher than many people perceive it to be, I can't envisage that many 98-year-olds using a smartphone. So there are limits in that regard. I think interesting with regards to some of the programs that certainly we're engaged with and are dealing with, often those developing countries are ones where the population base or the lack of a reimbursement program actually prevents a traditional human-based support program being put in place. And actually in those cases, it's probably one of the relatively few where a digital-only program does work, because it's significantly better than nothing at all.
And there was a question that clicked up about an elderly chronic ill patient, which I thought was quite a follow-up. I don't quite know whether we can...
There we go. How do you explain why elderly chronic patients participate, even if they date? So we went through a very detailed design process on that. So as I said, we put together a minimum viable product, and you co-create the program with them, and we iterated on it. So we stand up a prototype as early as we possibly can in the process. And the reason for that is that although we are all fantastically smart, we are not as smart as the patients who are actually going to use this. And we end up finding different information and little surprises as we go through the program. So what we did was we had 2 or 3 iteration cycles in order to optimize it, ensure that they were getting the right value coming out of it. That's why they engage.
Okay, thank you. Oh, one more question. So, which one to choose? The NHS initiative looks good, but is this actually helping patients, offering better care, or is it just helping the NHS to save money?
I think in their case it's doing both. So you'll see on the slide if anyone wants to download it afterwards, but it was reported 79% reduction in visits to primary care physicians and an 86% reduction in visits to the A&E department. So the objective of that program wasn't medication adherence. The objective of that program was improved patient self-management. Oh, that happens to save the NHS money, yes, but if you look at the verbatims and the patient satisfaction with the program was 95%, and most of the referrals onto the program actually came from other patients who had heard that a friend or somebody else was on the program and they referred them on.
Okay, thank you. And whilst we do have to move on in the agenda, I know Matt is going to be here, so if some of the questions that have come up...
Yeah, we have a booth outside if anyone would like to ask additional questions.
We'll be available to answer the questions. Thank you so much, Matt.